Half of all heart attacks occur in people whose cholesterol is completely normal. I need you to sit with that for a moment. Not slightly elevated, not borderline. Normal. 50% of people who suffer a heart attack had cholesterol numbers that their doctors looked at and said, "You're fine. Keep doing what you're doing. See you next year." And then their arteries closed anyway. That statistic comes from one of the most referenced observations in modern cardiology, and it should fundamentally unsettle everything you think you know about how heart disease is predicted and prevented, because it tells you something deeply uncomfortable about the system you're relying on to protect your life. The test that the entire medical establishment has used for over 6 decades to assess cardiovascular risk, the standard lipid panel, is missing half the people who are going to have a cardiac event. And yet, at your last annual checkup, your doctor almost certainly ordered that same standard lipid panel. A nurse drew your blood. The lab ran 4 numbers: total cholesterol, LDL, HDL, and triglycerides. Your doctor glanced at the LDL, compared it to a threshold, and made a decision in about 15 seconds. Either you were told you're doing great, or you were handed a prescription for a statin. That was the entire cardiovascular assessment. 15 seconds. One calculated number. And a sense of security that, for roughly half of all future heart attack victims, turns out to be catastrophically false. Today I'm going to dismantle that false sense of security. I'm going to walk you through 4 blood markers that predict heart attacks more accurately than standard cholesterol. Markers that are available right now, affordable, covered by most labs, and that your doctor has almost certainly never ordered for you. Not because these tests are experimental, not because the evidence is weak, but because the system is slow to change, and the standard lipid panel has been the default for so long that questioning it feels almost heretical. But the evidence isn't whispering anymore, it's shouting. And by the end of this video, you'll have a specific, written list of 4 tests to request at your next appointment. A list that could reveal hidden cardiovascular risk that your LDL number has been papering over for years, maybe decades. Let me start by explaining exactly why standard cholesterol testing fails. Because understanding the flaw is what makes the alternatives make sense. When your doctor orders a lipid panel, you get 4 numbers: total cholesterol, LDL cholesterol, HDL cholesterol, and triglycerides. The star of the show, the number everyone fixates on, is LDL, low-density lipoprotein, the so-called bad cholesterol. If your LDL is below 130 milligrams per deciliter, most primary care physicians will tell you you're in good shape. Below 100 and you'll get a gold star. Above 160 and you'll be having a conversation about statins. But here's the first problem most people don't know about. In the majority of labs, your LDL number is not actually measured. It's calculated using a formula called the Friedewald equation that was developed in the 1970s. That formula takes your total cholesterol, subtracts your HDL, subtracts a fraction of your triglycerides, and produces an estimate of your LDL. An estimate, not a measurement. An approximation based on assumptions about the ratios between different lipoproteins in your blood. And those assumptions become significantly less accurate when your triglycerides are elevated, which happens to be extremely common in adults over 60, in anyone with insulin resistance, in anyone carrying excess abdominal weight, and in anyone with metabolic syndrome. In other words, the formula is least reliable in exactly the population where accurate cardiovascular risk assessment matters most. Newer equations exist: the Martin-Hopkins formula, the Sampson equation, and they're somewhat better. But they're still estimates. You're still basing life and death decisions on a calculation, not a direct measurement of what's happening in your blood. But even if you could measure LDL with perfect accuracy, there's a second, deeper problem. And this one is the reason that half of all heart attacks occur in people with normal LDL. Here it is. LDL cholesterol measures the total mass of cholesterol carried by your LDL particles. It does not tell you how many particles are actually carrying that cholesterol. And it is the number of particles, not the total mass, that determines whether plaque builds up in your arteries. Let me give you an analogy that makes this concrete. Imagine a highway. What causes a traffic jam? Is it the total weight of vehicles on the road? Or is it the number of vehicles? You could have 20 heavy trucks or 200 small cars. The total weight might be identical, but the highway behaves completely differently. 200 cars create gridlock. 20 trucks flow through. Your arteries work the same way. Two people can have identical LDL cholesterol numbers. Let's say both are 110, both technically normal. But person A might have a small number of large, buoyant LDL particles carrying that cholesterol, while person B has a much larger number of small, dense particles carrying the same total mass. Person B has dramatically more particles hitting their arterial walls, more particles embedding, more plaque forming, more risk. And the standard LDL test shows the same number for both of them. This is called LDL discordance, and it happens in a staggering proportion of the population. Your LDL says you're safe. Your actual particle count says you're in danger, and nobody measured the particle count. This brings us to the first blood marker that changes everything: apolipoprotein B, ApoB. This is the test that does what LDL pretends to do. Here's why. Every single atherogenic lipoprotein particle in your blood, every LDL particle, every VLDL particle, every IDL particle, every LPA particle, carries exactly one molecule of a protein called apolipoprotein B on its surface. One particle, one ApoB molecule. Always. Without exception. Which means when you measure ApoB concentration in the blood, you're getting a direct, precise count of every single dangerous particle in your bloodstream. No estimation, no formula, no assumptions about ratios. A direct measurement of the actual number of particles that drive atherosclerosis. A comprehensive review published in the European Heart Journal in 2025 examined decades of accumulated research and concluded definitively that ApoB is a more accurate predictor of cardiovascular events than LDL cholesterol, or non-HDL cholesterol. In 9 out of 9 comparative studies reviewed, ApoB outperformed LDL as a predictor, 9 for 9. And critically, when the two measurements disagreed, when someone had normal LDL but elevated ApoB or vice versa, it was the ApoB that correctly predicted who would go on to have a cardiovascular event. The Cardia study provided some of the most compelling long-term data. Researchers followed young adults over 25 years and found that those with high ApoB but normal LDL cholesterol had a 55% higher risk of developing coronary artery calcification, a direct measure of plaque in the arteries, a quarter century later. Meanwhile, those who had high LDL but normal ApoB showed no increased risk whatsoever. Let me say that again. High LDL with normal ApoB, no extra risk. High ApoB with normal LDL, 55% increased risk. The ApoB was telling the truth. The LDL was telling a story that felt reassuring but was fundamentally misleading. The European Society of Cardiology and the Canadian Cardiovascular Society have both formally recommended ApoB over LDL for cardiovascular risk assessment. And as of 2026, the updated American Heart Association and American College of Cardiology dyslipidemia guidelines now formally recommend ApoB measurement for adults on lipid-lowering therapy. What should your number be? For standard cardiovascular prevention, an ApoB below 90 milligrams per deciliter is considered acceptable by most guidelines. Below 80 is where you want to be if you're serious about protection. For aggressive long-term prevention, particularly if you have other risk factors. Some leading cardiologists recommend targeting below 60. The test is a simple blood draw. It's available at virtually every standard laboratory. It costs almost nothing. And it could be the difference between a false sense of security and an accurate picture of your risk. The second marker is the one that I believe should fundamentally reshape how we think about heart disease. It's called high-sensitivity C-reactive protein, HSCRP. For 6 decades, cardiology has been laser-focused on cholesterol. Cholesterol builds the plaque. Lower the cholesterol, stop the plaque. Prevent the heart attack. That framework isn't wrong. Cholesterol is necessary for plaque to form, but it is radically, dangerously incomplete. Because cholesterol alone doesn't cause a heart attack. If cholesterol simply accumulated in your arterial walls and sat there quietly, you'd have narrowed arteries, but you wouldn't have a sudden, catastrophic event. What causes the event, the actual moment when someone clutches their chest and collapses, is the rupture of that plaque. And what causes the rupture is inflammation. Here's the sequence. Cholesterol-carrying particles embed in the arterial wall. Immune cells detect them as foreign invaders. Those immune cells infiltrate the area and begin an inflammatory response. Over years and decades, this inflammation weakens the fibrous cap that holds the plaque stable. The cap thins. It becomes fragile. And one day, often triggered by a blood pressure surge, a stress response, or a morning cortisol spike, the cap ruptures. The contents of the plaque spill into the bloodstream. A clot forms instantly. The artery blocks. Tissue starves. That's a heart attack. Every single step from the initial cholesterol deposit to the fatal rupture is orchestrated by inflammation. If cholesterol is the fuel, inflammation is the fire. HSCRP measures that fire. Your liver produces C-reactive protein in response to chronic, low-grade inflammatory signals throughout your body. The standard CRP test detects levels above 10 milligrams per liter, useful for identifying acute infections, useless for cardiovascular risk. The high-sensitivity version, HSCRP, detects much lower levels of the kind of chronic, smoldering inflammation that drives atherosclerosis over decades. A landmark study conducted by Paul Ridker at Brigham and Women's Hospital enrolled over 28,000 healthy women and measured 12 different blood biomarkers simultaneously to determine which one best predicted future cardiovascular events. The result was unequivocal. HSCRP was the single strongest individual predictor. Women in the highest quarter for CRP had 4.4 times the cardiovascular risk of women in the lowest quarter. That predictive power was stronger than LDL cholesterol, stronger than total cholesterol, stronger than homocysteine, interleukin-6, or any other marker tested. In September 2025, the American College of Cardiology published a formal scientific statement confirming that HSCRP strongly and independently predicts cardiovascular events, and that elevated levels place otherwise healthy individuals into a higher risk category, even when every other number on their blood work looks perfect. Their recommendation? Universal screening. Not targeted, not occasional. Routine measurement alongside cholesterol. What should your number be? Below 1.0 milligrams per liter. Low risk. Your inflammatory burden is under control. Between 1.0 and 3.0. Moderate risk. There's something creating inflammation that deserves investigation and intervention. Above 3.0, high risk. You need to find the source and address it aggressively. For context, roughly 52% of Americans currently have an HSCRP above the optimal threshold. Half the adult population walking around with active arterial inflammation that nobody is measuring. And here is what makes HSCRP particularly powerful compared to some other markers. It is highly modifiable. You can bring it down. Dietary changes, particularly increasing fiber from beans, vegetables, nuts, seeds, and berries, along with olive oil, green tea, and omega-3 fatty acids, have been shown to reduce hsCRP meaningfully. Exercise is remarkably potent. Published data shows that increasing daily steps from 2,000 to 10,000 reduces CRP by approximately the same magnitude as starting a statin. Weight loss, especially reducing visceral fat around the abdomen, is one of the most effective interventions. Quitting smoking produces a significant and rapid drop. Even improving sleep quality and reducing chronic psychological stress have measurable effects on CRP levels. You can fight this one, you just have to know it's there first. The third marker is lipoprotein A, written LPA and pronounced LP(a). If ApoB is the test your doctor should be ordering, and hsCRP is the test that should reshape screening, then LPA is the silent genetic ambush that no one warned you about. LPA is a modified form of LDL cholesterol. It has the same cholesterol-carrying particle, but with an additional protein called apolipoprotein A wrapped around it, like barbed wire around an already dangerous projectile. This protein makes the particle stickier, more likely to embed itself deeply in arterial walls, and harder for your body to clear. But LPA does something even more dangerous. It promotes blood clotting. It inhibits fibrinolysis, the process by which your body dissolves clots. So LPA is simultaneously building plaque faster and making it more likely that when that plaque ruptures, the resulting clot will be larger and more persistent. About 1 in 5 people, 20% of the population, carry genetically elevated LPA levels. These individuals can eat a pristine diet, exercise every day, maintain perfect weight, have textbook LDL cholesterol, have normal blood pressure, and still carry dramatically elevated cardiovascular risk because of a genetic marker that has never appeared on any standard blood panel they've ever had drawn. This is almost certainly the most common explanation for the phenomenon that terrifies everyone. The seemingly healthy person in their 40s or 50s who has a devastating heart attack or stroke with absolutely no warning and no obvious risk factors. The risk factor was there the entire time, embedded in their DNA, circulating in their blood at dangerous levels. It simply was never measured. Here's what makes LPA unique among cardiovascular risk markers. Your level is almost entirely determined by your genetics. Diet doesn't meaningfully change it. Exercise doesn't lower it. Weight loss has minimal impact. Standard statins don't reduce LPA, and some data actually suggests that certain statins may slightly increase it. There are currently no FDA-approved medications specifically designed to lower LPA, though several candidates in Phase 3 clinical trials, including antisense oligonucleotide therapies, have shown dramatic reductions, and effective treatments are widely expected to become available within the next few years. So why test for something you can't yet directly treat? Because knowing changes everything about how you manage your overall risk. If your LPA is in the dangerous range, your cardiologist should set tighter targets for every other modifiable factor. Your ApoB target drops lower. Your blood pressure management becomes more aggressive. Your hsCRP needs to be brought down as far as possible. You compensate by controlling every lever you can pull with greater intensity, because one lever is locked in the wrong position by your genes. LPA should be tested once in your lifetime. Since it's genetically determined, it doesn't fluctuate significantly over time. One measurement gives you your answer. If your level is elevated, every blood relative, siblings, children, parents, should be tested as well. It's inherited. If you have it, the people who share your genetics may have it too. The fourth marker is one that surprises almost everyone because they associate it with diabetes, not heart disease. It's fasting insulin. And the evidence connecting insulin resistance to cardiovascular risk is, frankly, staggering. Here's what most people understand about insulin. You eat food. Your blood sugar rises. Your pancreas releases insulin. Insulin tells your cells to absorb the sugar. Blood sugar comes back down. Simple. What most people don't understand is what happens when this system starts breaking down, which it does gradually in an enormous portion of the population as they age. Insulin resistance is the condition where your cells become progressively less responsive to insulin's signal. Your pancreas compensates by producing more and more insulin. For years, sometimes decades, this compensation works. Your blood sugar stays normal because your pancreas is flooding your system with insulin to force the glucose into resistant cells. Your fasting glucose looks fine. Your doctor says everything's normal. But behind the scenes, your insulin levels are climbing steadily. And those chronically elevated insulin levels are quietly devastating your cardiovascular system. How? Through multiple simultaneous mechanisms. Chronically elevated insulin promotes systemic inflammation, directly raising your hsCRP. It increases triglyceride production, which shifts your LDL particles toward the small, dense, dangerous pattern we discussed earlier. It promotes blood clotting through increased plasminogen activator inhibitor. It stiffens your arteries by promoting vascular smooth muscle proliferation. It drives visceral fat accumulation around your organs, the most metabolically dangerous type of fat. It is, in many ways, the metabolic engine running behind the scenes of metabolic syndrome. The cluster of high blood pressure, high triglycerides, low HDL, abdominal obesity, and elevated blood sugar that collectively represent the single largest cardiovascular risk pool in the developed world. In the Quebec cardiovascular study, men with the highest fasting insulin levels had more than 5 times the risk of heart disease compared to those with the lowest levels. 5 times. That risk multiplier was larger than the risk from elevated LDL, larger than the risk from elevated ApoB. And here's the finding that should terrify every physician who relies solely on cholesterol screening. Men in this study who had normal cholesterol but elevated insulin still had significantly increased cardiovascular risk. Their lipid panels said they were safe. Their insulin said they were in danger. And nobody was checking the insulin. Your standard annual blood work almost certainly checks fasting glucose. It almost certainly does not check fasting insulin. And this is the critical blind spot. Fasting glucose is one of the very last markers to become abnormal in the progression toward metabolic disease. Your insulin can be elevated for 10 to 15 years before your glucose finally rises enough to cross the diagnostic threshold for prediabetes. By the time your fasting glucose is flagged, the cardiovascular damage from hyperinsulinemia has been accumulating for well over a decade. You've been in danger for years. You just couldn't see it because nobody ordered the right test. What should your fasting insulin be? Below 5 microunits per milliliter is optimal. Between 5 and 10 is acceptable but worth monitoring with lifestyle attention. Above 10 warrants serious investigation and intervention. Dietary changes, exercise, and possibly medication. Above 15 suggests significant insulin resistance that is actively, right now, accelerating your cardiovascular risk with every passing day. The test is a simple fasting blood draw, available at any lab. Costs very little, and for millions of people it would reveal the hidden metabolic fire that no lipid panel was ever designed to detect. Let me bring everything together. Here is your list. Write it down. Take a photo. Print it out. Put it with your insurance card. Test 1. ApoB. The actual count of dangerous particles in your blood. More accurate than LDL in 9 out of 9 comparative studies. Target, below 90, ideally below 80. Test 2. hsCRP. Chronic inflammation. The mechanism that triggers heart attacks. The strongest single predictor in a study of 28,000 women. Target: below 1.0. Highly modifiable through diet, exercise, and lifestyle. Test 3, LPA. The genetic wildcard. Elevated in 1 in 5 people. Test once. If high, tighten every other target. Tell your family to get tested. Test 4, fasting insulin. The metabolic engine that drives risk for a decade before glucose catches up. Target: below 5 to 10. Never included on standard panels. 4 tests. All available. All affordable. Together, they paint a picture of your cardiovascular reality that a standard lipid panel was never designed and is fundamentally unable to provide. Everything I've shared today is educational information based on current published research and the latest clinical guidelines from the American Heart Association, the American College of Cardiology, and the European Society of Cardiology. This is not personalized medical advice. Your situation is unique. Before making changes to your medications or screening approach, bring this list to your physician. Have the conversation. Ask for these tests by name. That conversation, informed, specific, and backed by evidence, is exactly where better cardiovascular care begins. What tests did your doctor order at your last checkup? Have you ever had ApoB, HSCRP, LPA, or fasting insulin measured? Or have you only ever seen a standard lipid panel? Tell me in the comments. I genuinely want to know how many of you have been screened with these markers versus how many are relying on a 60-year-old testing protocol that misses half the people it's supposed to protect. Share this video with someone who was told their cholesterol is fine and their heart is safe. That assumption is exactly what this video was made to challenge. Subscribe for more evidence-based content. Take care of your heart. I'll see you in the next one.